Welcome to Webinar Wednesday. Today we have Julia Bareham from the University of Saskatchewan College of Pharmacy and Nutrition with the RxFiles. And what she's going to be doing today is giving us an orientation to the RxFiles, objective comparisons for optimal drug therapy. Welcome to today's webinar, and thank you for joining us today. My name is Carol. I'm a registered nurse and a nursing advisor in the practice team here at the SRNA. My role today is to help facilitate the webinar. Our topic today is an orientation to the RxFiles objective comparisons for optimal drug therapy. And this is being presented by Julia Bareham, who is from the U of S, and the RxFiles are housed at the College of Pharmacy and Nutrition. Before we get started, I have a couple of notes on how you can engage throughout the presentation. As a viewer of this webinar, you'll be able to hear and see the presentation. Only the panelists will be able to speak throughout the presentation. If you have a question, add them to the Q&A. We will be monitoring this area for questions throughout the webinar, and these questions will be answered they'll be answered live. If you wish to send your questions anonymously, just check the box at the bottom of the Q&A screen. We will be recording this webinar, and it may be posted on the SRNA website for those who are not available to join us today to view at a later date. An email will be sent with a link to the evaluation. We hope that you take a couple of minutes to complete the survey. And I'd just like to acknowledge that as we gather here today, we acknowledge that we are in Treaty 2, 4, 5, 6, 7, 8, and 10, and the homeland of the Métis. We pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. Now that we have the housekeeping items out of the way, I'll turn the microphone over to Julia.
Thanks so much.
Okay.
So I got all the technology glitches out of the way. Should be smooth sailing from here on. Okay, well, thanks for tuning in today. I suspect this might be your lunch hour or perhaps your time off. So what I'd hope to do today is introduce you to the RxFiles resource if you're unfamiliar with it, and provide you with some tips and tools on how you might make the best use of this resource. I think most importantly on this first slide is my email address. It's julia@rxfiles.ca. We've got the best email addresses, easy to remember. If there's anything that you require after today, you're struggling to access our resources, you're looking for a point of clarification, maybe because you're watching the recorded session, please don't hesitate to reach out and ask any questions. So just a quick disclosure slide. I am employed by RxFiles Academic Detailing, and as Carol mentioned, we are located at the University of Saskatchewan, but we do get our funding from the Ministry of Health here in Saskatchewan. I also work casually with Shoppers Drug Mart. I am a committee member with the Drugs and Therapeutic Advisory Committee for NHB, or Non-Insured Health Benefits, through Indigenous Services Canada. And none of the work I do is funded through the pharmaceutical industry. So it's really important to RxFiles to ensure we're providing objective, non-biased information to healthcare providers across Saskatchewan. So what I hope to do today is, if you're unfamiliar with RxFiles, or maybe you are, perhaps I can teach you something new about what we might offer, a cool tool or resource that you might find valuable that you can use in your practice, how to access RxFiles resource and tools, because we never want there to be a barrier for you to get a hold of those, make you more familiar with what type of information or tools or resources that you can find on our website, on our app, and our books. And then, of course, how do you use these tools? Because if you have never seen an RxFiles chart, prepare yourself, it can be a little overwhelming. So I know we've got a few live participants today. So I'm going to do something a little wild and crazy and see if this works, trying to navigate a chat box and a presentation. But if you have a drug therapy question about type 2 diabetes, feel free to throw it in that Q&A box, and I'll see if I can answer that. Will I show you how the tools work? I fear I would just bore you to death if I just told you, oh, this is what our tools are, and this is the type of information we contain. So today I thought most people are probably encountering type 2 diabetes in their practice. So maybe I can use that therapeutic area to help make the information more relevant. So at any point, if a question comes up, feel free, again, to throw it in that Q&A box, and I'll try and keep an eye on it. So let's just jump into it. What is RxFiles? Well, really, we are we are an academic detailing service, right? So we go out and we provide objective, comparative drug information to clinicians. And really, we're focusing on prescribers, but that doesn't mean that we exclude any other healthcare provider. Of course, we detail pharmacists, nurses, whether it's LPNs, RNs, NPs. Just last night, we were presenting to the chiropractors and registered massage therapists. And really what our goal is to present to you the evidence in the information around a drug therapy area. So let's say around, for example, type 2 diabetes or around osteoporosis, and give you all the medication options and non-drug options and let you see all the evidence so you can compare them and then apply that information to the patient in front of you, because there's never a one-size-fits-all sort of best drug or treatment option for every patient. So again, we don't say what's right or wrong. We just say, here's what we know. You know what, sometimes here's what we don't know. Take this information and know that it's evidence-based so that you can use it to help, again, optimize drug therapy. We are a provincial program, so you can access RxFiles services anywhere in Saskatchewan. Doesn't matter how far north, south, east, or west. We have academic detailers located all over Saskatchewan. And again, as I mentioned previously, we do get funding from SaskHealth to operate our program. But in Saskatchewan, our tools and resources are free to any healthcare provider. But if you make the mistake of moving to Manitoba, Alberta, or somewhere else, just kidding, of course, that wouldn't be a mistake. You'd just be leaving one of the best places to live in Canada. You would have to pay to access our resources. And so that's how we further fund our program, through the sale of either those printed books that we have or our digital tools. And again, we do not accept any funding from any pharmaceutical companies. So what types of resources do we have? Well, our claim to fame are what we say are up-to-date drug comparison charts. And that's where you're going to find all the drug therapy options on 1, maybe 2 pages. And we say up to date because on our website, we're updating that information weekly, easily. On our app, which you see in the middle, a bit slower to get those updates updated through Apple and maybe through Google Play. So maybe those are taking every 3 months. And as you see on the far right, we do have print resources. Those are our books. So that brown one holds all our drug charts. We print one about every 2 years, and currently we're on the 12th edition. 13th should be out this fall. And then we also have a geriatric focused book, and that's on the bottom. So of course, once they're printed, we can't update those until we do our next print, but our website is where you can always go for the most current information. We have newsletters, Q&As, trial summaries, and patient tools. And again, using the therapeutic area of type 2 diabetes, I'm going to walk you through some of those resources so you can see if there's a tool there that might help you, and again, help you in your practice. If you are on an SHA work site, whether you're in a hospital or perhaps a long-term care home, for example, you should have automatic access to RxFiles just to that IP address because of where you're located. If you're having trouble, let me know. We can easily fix that. But maybe you're at home or you're working out of a private practice and you want access to RxFiles. Well, we recommend that you register for SHRP, the Saskatchewan Health Information Resource Program, so you can get access to RxFiles easily for free. There's a few other ways you can get it through eHealth Viewer, for example. But the beauty of SHRP is that you get access to a variety of other great resources. One I use quite frequently out of here is the Natural Medicines database, for example, so that when folks are asking me about a vitamin, a mineral, natural product, I can check out the evidence there. So there's one tip of the day. Do check out this resource if you don't already have free access. It takes about 24 hours to get approved. So you want to do it before you need it because there might be a bit of a delay. Oh, and there, right here, that's where you go just to click in to log in or sign up for your free account. All right, now here comes the overwhelming portion of the show if you have never seen an RxFiles chart. Boom, busy. You probably can't read a single word on your screen right now, especially if you've got a smaller screen, and that's okay, because we're going to sort of go through the anatomy of these busy charts, because most people are instantly turned away because they're going, A, my eyes can't focus on size 6 font, B, there's too much, I don't even know where to start. So let's start right now. When you just sort of look at this chart really quickly, maybe a few things that jump out at you are the colors. You might see some purple, highlighting some yellow, and a little bit of red. So let's start there. When you open up an RxFiles resource and you see that shading, we use that to denote different aspects that you might be interested in. If you've got just a few seconds, look for what's yellow, especially yellow with bold font, because that's meant to draw your attention. It's important. That's where the differences lie. That's where the practice gaps are. That's where our common questions are. Green generally means it's a non-drug, herbal, or lifestyle option. So if you're looking for non-drug options to recommend, look for green. Blue is going to denote our younger patient population, pediatric adolescents, where that tan is more our older adults. Purple means it's a guideline, and red means, this is a warning. Pay attention. This is a black box warning. Important. Stop. Look at this information. So there's just a few tips there. So if you quickly look back, got ahead of myself there, at this chart, you can see that purple under comments. So these are the GLPs and the SGLT2, those newer drug classes in type 2 diabetes. So right away you can see, okay, there's some purple information here. What are the guidelines recommending? And you see DC for Diabetes Canada and ADA as our reference, the American Diabetes Association. They're recommending these new classes of medications as second line for type 2 diabetes if cardiovascular disease might be present. Then I'm seeing some yellow and yellow bold, right at the top, a little over to the right, common adverse events, GI issues with the GLP-1 agonist. So start low, sort of slowly increase, okay, good tips. And there's those red sort of highlighting, there's some reports about thyroid C-cell tumor. That could be a bit concerning. So there's a little bit of information around that. Well, it might be only with liraglutide. It's mostly data in mice and rats. So is that a big concern? We're not too sure. But we do present other black box warnings there, as you can see. Might see some blue for some adolescent dosing and some tan over on the right to indicate you might want to be cautious in your older adults. So hopefully already that's showing you a bit of the anatomy and some of the tips on navigating this very busy page. There's a few other things I want to highlight, and I'm going to sort of blow up this left-hand side. So that's where you're going to find all your drug names, and you might go, well, what is this? There's X in a circle on the Ozempic. There's a phone and a triangle. Well, those actually denote drug formulary coverage. And because we're a Saskatchewan-based resource, the one on the left is always SaskHealth, and the one on the right is always NHB. And I'll show you where to figure out what those symbols mean further. You'll also find P and L next to many medications. Many of our charts, that's our pregnancy and lactation category. So is this safe in pregnancy? Is this safe in lactation? And if you go over to the right and maybe you're looking at the dosing information, you'll see a kidney, and the kidney is saying, you know what, you might need to adjust the dose if there's some renal insufficiency. And we define there sort of what is the eGFR cutoff and how do you want to approach that? Maybe you just want to be cautious and avoid, or maybe you just want to decrease the dose. So both on our website and our books, you'll find sort of what do those symbols mean. On the far left, you see the X's. Again, X means non-formulary Saskatchewan. The phone means I have to phone for EDS. The circle X means not covered by NHB, and so on. And again, you can see we have at the very bottom on the left-hand side, the liver and kidney symbols to denote the need for dose adjustment when there's renal and hepatic impairment. And on the right, there's our pregnancy and lactation categories. We use a traffic-like approach in many of our resources. So green means go, safe. And when you get into the red, it means you should stop, think about it, look into this further, because maybe this isn't the most appropriate or safest option for a patient who's either pregnant or breastfeeding. So here again is a very busy, overwhelming RxFiles chart. This happens to be sleep and insomnia. So I just want to show you what type of information is contained in all of our charts. You're always going to get the generic name. It's going to be bold and a lowercase. And then you're going to get the brand name or the trade name. And we always put that in purple. If you see it in gray, it means it's just no longer available as a brand name product, like the patent's expired and the pharmacy, for example, couldn't order that in. You'll also see all the strengths and formulations available. So it turns out mirtazipine's available in a 15, 30, and 45. And if you really dig into our symbols, if it's got a little squiggly next to it, it actually means the tablet is scored and is easily split. Drug interactions, denoted by the DI abbreviation. What are the most common drug interactions to be aware of? What is the cost? And this is always listed in Canadian dollars and for a quantity that's generally dispensed in Saskatchewan. So for example, sleep and insomnia drugs, they're going to be for about a 34-day supply, as opposed to the diabetes medications, which are generally a 100-day supply. So that will be reflected and definitely noted in that column. You'll also find common contraindications. Who should this medication be avoided in, just to ensure the safe use of this medication? What are the common side effects or adverse effects that patients might expect when using these medications? And sometimes we provide sort of incident rates, but generally the most important ones come first or are bolded or highlighted. Is this covered? Because it's great if we think a drug is the drug for our patients, but if they can't afford it and they don't have drug coverage, this could be an important consideration for some. Here in this chart, you'll see the pregnancy and lactation categories are hiding next to the dosing recommendations. And in some charts, there are some over-the-counter products available, and that will also be denoted. So something you could send patients to the pharmacy to pick up themselves. So, a lot of information all hidden in there, but the idea is now you know all the options in this case for sleep and insomnia. How long will it take for them to kick in? How long will it last? We've got an average half-life there. How well does it work? How much more sleep am I really going to get? And when you dig into these charts, it's a bit shocking to find that, oh my goodness, I'm only going to get 15 minutes more sleep. Is that actually worth all those possible adverse events and the cost associated with that medication as well? So this is a standard approach to an RxFiles chart, but we do something else. And this is more of, again, an overview of all the drug treatments. I suspect you cannot read all the words on this page, but when you see these color comparison charts, it can again help guide you to maybe which medication might be best for my patient. When we have a drug color comparison chart, across the top, we've got all the options. And here we've come back to diabetes. How do we treat diabetes? Here's every drug option we have by drug class. Down that left-hand column, what do we care about when treating diabetes? Do we actually reduce the risk of death or major cardiovascular concerns? That's really important, hence why it's at the top. How does this affect A1C, right? Our treatment targets? Am I going to be putting my patient at risk for hypoglycemia? What about if they have heart failure? And so on as you go down that column. And at the bottom, just a reminder of what those colors mean. Green is an advantage. Red, again, stop, slow down. I need to think about this. So if you quickly look at this chart, I suspect you're maybe drawn to metformin, the first drug, our first line therapy for most patients. You see a lot of green, great option. But if I'm thinking about, okay, what might I need to add on in a heart failure patient? I can go to that heart failure row and look across for some green, and then immediately my eye is drawn to the SGLT2 inhibitors. And if I'm thinking about what's next, that's probably where I'm going to dig a bit deeper and probably then go to the drug chart to get some more detail about which one of those particular options might be best for my heart failure and type 2 diabetes patients. So lots of ways to find the optimal therapy for your patients. This is a bit more of a high level one with a color comparison, and then you get into, again, the detail with those charts. But we're just not all drug charts, even though it's how we started out and what I find most prescribers use most often. But we're also newsletters. And this is a screenshot from one of our landing pages on our website, rxfiles.ca. And you see this nice visual, so you can click on a newsletter. What's a newsletter? Well, if you are not a fan of these busy charts, a newsletter essentially takes that information and puts it into prose. So we have sentences and information and a bit more structure around what you might be looking for. So here is our update on type 2 diabetes newsletter, specifically looking at the non-insulin options, because it was such a big topic, we had to cut it down into non-insulin and insulin. What might you find as you flip through the pages here? Well, there are a variety of interventions for type 2 diabetes. How well do they work for lowering A1C? We've got nutrition and exercise right at the top, highlighted in green because these are non-drug options, and you can see that no drug will lower A1C better than nutrition. And as we add on different drug therapies, you can see what you might expect in terms of A1C lowering. So perhaps you're looking to get the most out of A1C lowering, so you might be considering metformin or first-line option, maybe a sulfonylurea, repaglinide, GLP-1s, all depends on the patient. As you flip through further, you might go, okay, so I've got my patient started on metformin. We're trying diet and exercise, but we're still not where we want to be. What else can I add on? What's the second line agent? Because really the guidelines don't say one second line agent is better than the next for every patient. So there's some considerations you can make. Are you concerned about the adverse event profile? And here are some of the medication classes and some of the common adverse events that may occur. Are you really worried about that patient going low and avoiding hypoglycemia? Well, then you might want to avoid insulins. You might want to avoid sulfonylureas. Are you looking for convenience? Because you've got a patient who's on the go and it's like, look, I can only take a drug once a day. I want minimal dosing. What are my options? Is cost a factor? Are complications a factor? Are you dealing with pregnancy or older adults? All those considerations are explored there with some suggestions around which medication class or medication might be optimal for that particular patient. So we're really evidence-focused. We want to present to you, what does the evidence say? What do we know? How well do these medications work? And put it into context so you can help really compare them. And in that newsletter, again, you'll find the potential benefits of these newer agents, SGLT2 inhibitors and GLP-1 agonists. How well do they work to actually decrease your risk of death? And if I take you right to the top there, the empagliflozin, we see a number needed to treat of 39 over 3.1 years. And the name of the study that came from, the EMPA-REG. So for every 39 patients that I treat with this particular drug therapy over 3 years, I'm going to prevent one death. And that may not sound very impressive at first, but preventing a death is huge. And to only have to treat 39 people to accomplish that, I think that's pretty beneficial, remembering that these medications are also lowering blood sugars, which can lead to other microvascular complications as well. Maybe you're worried about major adverse cardiovascular events or MACE. How do the options compare? Because you've got a patient in front of you with a history of cardiovascular disease. There's the evidence. Maybe you're more worried about kidneys and you want to look at the neuropathy endpoints. Well, canagliflozin probably has the best evidence out of that Credence study to suggest a benefit. And if you've got a heart failure patient, we're looking at dapagliflozin with a number needed to treat of only 21 over a year and a half of treatment. So again, those are some of the sort of pearls and information that you might find as you dig into those multiple paged newsletters. The other type of resource we have, we call them Q&As. So often we're trying to address maybe a clinical controversy that everyone's talking about. And we try to be as current as we can. So I recognize that maybe this is not the most current one, but I wanted to draw on diabetes again. To aspirin or not to aspirin? Are we supposed to recommend it? Or are we not supposed to recommend it? It seems like we've moved over the years. So in this quick 2-page document, we look at the evidence. And what we say is, here's what we know. We looked at these 3 really big trials, and in the end, they took ASA compared to no ASA or placebo for people who have not had an event yet. And what we found is that ASA consistently increases the risk of bleed and offers very little, if any, benefit for some, and those with diabetes might be a modest benefit. So if you're worried about the diabetes population or an individual who has diabetes, the ASCEND trial is where you want to look. You see green, good, red, concerning. So some numbers, you're like, oh, relative risk 0.88 for a cardiovascular outcome, but relative risk of 1.29 for major bleed. What do these numbers mean? Number needed to treat, number needed to harm. How do I have these conversations about this very close numbers for benefit versus risk with my patients? And then you go to page 2 of this Q&A, and we talk about translating the evidence for patient discussions. I like using numbers needed to treat. Sometimes that risk reduction helps, but saying, you know, if we treated 91 people with low dose ASA for 7.5 years, we might prevent 1 heart attack or 1 stroke or 1 TIA. But even though we prevented that 1, we're going to have 1 out of 112 are going to bleed. And that's going to be a major bleed. It's going to require probably acute medical attention. So those numbers are pretty close. So your benefit versus your risk, they're pretty tight. Do you feel like that's a risk you want to take for that potential benefit? Yes or no? And sort of helping guide the patient through that decision so they can make the best choices for their health. Next, if you're really into the evidence, trial summaries, and this is, of course, we are super nerds at RxFiles and we love the evidence, and I want to know what that trial said. So you will also find those on our website. Have you ever wondered if pushing someone to a lower A1C value is really doing them much good? Well, if I'm looking at my type 2 diabetes patients who have had long-standing diabetes, so about 8 to 12 years, just going to enlarge this so maybe you can see. There's a few trials I might look at and go, you know what, is this worth adding on a 3rd or a 4th agent to control your blood sugars? So when we looked at 6.4 versus 7.5 as a target for A1C, because that's what people actually achieved, no significant findings for microvascular, macrovascular. Turns out we actually caused more harm than we did good. There was an increased risk of mortality. And then the advanced trial, very similar numbers, 6.5 versus 7.3 were achieved. You know, there's a bit of a different population, perhaps, little improvement in the nephropathy. But with those big cardiovascular outcomes, the major adverse cardiovascular events are all-cause mortality, we didn't see any difference. So to me, this says, do I want to push that target to a lower number, or am I fine when my patient is at 7.5, even though the guidelines say 7? This sort of helps me make a better informed evidence-based decision and to have that conversation with the patient as well. And speaking of patients, we have a variety of patient tools on our website. And as you scroll down, you'll see clinical tools there that you click on. There are many. Some you might be interested in are our patient booklets. And so I've got the type 2 diabetes one up here, but we have a variety of topics around harm reduction and injecting drugs, around buprenorphine, naloxone, or Suboxone for chronic pain, around benzodiazepines and sleep or anxiety. We have crystal meth coming, alcohol use disorder, many booklets. And these are open access. You could email them to your patients. You can print them off. You can see color or black and white. And when you open them up, they're meant to be patient friendly. We tried to minimize the words as best we could, but here's some patient tools around sick day management and which medications to hold, signs of dehydration. Very, again, visual, meant to engage the patient. If you think these booklets are something that your practice, your patients, or you personally might benefit from, we were fortunate enough to receive a grant through Health Canada to support the printing and distribution of these booklets. So if you wanted 50 copies of these tomorrow, well, you've got my email address, julie@rxfiles.ca. Just let us know. Check out the website to see if there's any booklets you would like. We're happy to support that. And right now, like, you don't have to be shy. You want 200 booklets? That's something that we can support currently, no problem. Other resources you might find related specifically to type 2 diabetes, an exercise prescription. So we tried to make this a bit more realistic because not everyone is already physically active. So we want to recognize that we might be going from the couch to our first time maybe doing exercise in a long time. And we've got some information that's just sort of cut off a little bit down there about what's realistic aerobic activities and strength activities. And I can tell you, it's not doing 400-pound squats and running marathons. It's meant to be very low intensity, gradual, and increasing over time. So a great tool for the patient who's looking to leave that encounter with something in their hands. Here's your prescription. Happens to be for exercise, not a pill. Another tool that I think is very valuable and something that I've tried to incorporate into my community practice, because honestly, I feel like I do not do a good enough job about communicating when to hold medications when patients are sick and thus acutely dehydrated. And our concern, especially in diabetes, is that we can cause some hypoglycemia or as well cause an acute kidney injury. So this is a tool. We actually have them in like tear-off pads. If it's something you want to also implement into your practice, let me know. We can send you a couple pads where you can personalize it for the patient. Write down if they are taking a sulfonylurea and which one it is. What is their ACE inhibitor called? Oh, it happens to be ramipril. And on the other side of this page, we do have a list of all these medication names by brand and chemical. And they can take this home and put it on their fridge as a reminder of what to do to pause those medications when they are having the following symptoms, how to hydrate, when to restart those medications, and when to really start recording those blood sugars and potentially reach out to their healthcare team because they may be getting into some trouble around blood sugar control or maybe significant dehydration. So a great tool that I quite like and actually personally try to use as much as I can. But because we're still navigating all these new drug classes, the SGLT2s, and we do have one of these on the GLP-1s as well, this is an infographic, if you will, to help have that discussion around what are the risks of these new medications. So what are the common adverse events? As we go to the bright, closer to the flashlight there, you'll see common side effects like thirst and increased need to pee, if you will, a decrease in blood pressure. We can expect that with most patients with these medications. But what about these amputations I've heard about? Is that really a risk? Well, we try to provide a bit of context around specific to canagliflozin. The Canvas trial indicated perhaps this could be a problem for major ankle or above the knee with those number needed to treat. But when the Credence trial did it, they actually didn't find a significant difference. So we're not really sure if this is a risk, but until we do, I might avoid this particular agent in patients that I might identify as at risk. Or perhaps there's just a better agent that I may choose over this one because I'm not sure. And that's what these tools are meant to do. Sort of, again, give you more of that information to put, like, when we talk about risk, put it into context. How risky is it? Because a common side effect is 10%, right? And a rare one can be a couple decimal points. So I think it's important for patients to understand that. And that information is also hidden back to this busy chart again. You will find that with the SGLT2s. If you look into the adverse events, you can see, again, highlighted in red, acute kidney injury. What do we need to monitor for? That increased serum creatinine. Be careful when it goes up greater than 30. Ooh, there's an increased risk of genital mycotic infections, especially in females, and increased risk of UTIs, diabetic ketoacidosis, and then you see again that canagliflozin increased risk of fracture. So there you have a hazard ratio of 1.3 according to Canvas. Yet again, Credence was unable to find the same finding. So all that information is always in the chart. Just sometimes it's nicer to pull it out into those more visual tools and resources, especially when you want to focus on a certain area or discussion topic. And back to those color comparison charts, this information, again, looking at those SGLT2s, just another way to present the info. If you've decided this is the class of medication that you might want to explore with a patient, here's how our 3 common options compare. Most important stuff is at the top. Does this actually decrease the risk of major cardiovascular concerns? I'm not going to lie, if I'm going to use it, I'm probably going to lead toward the ones that have green in the evidence to support its use. So DAPA and CANA might be an option. As I scroll down and I look to heart failure, I'm seeing more green on EMPA. And then they're pretty much comparative down as you go down the color comparison chart. And this might explain why Diabetes Canada has recommended empagliflozin as perhaps one of their preferred options for most patients. Now, to quickly switch gears to go over to insulin, another important part about managing type 2 diabetes. You can see how sometimes we try to find creative ways to communicate what might be important when it comes to decision making around a particular sort of drug therapy class or indication. So how do you choose an insulin when the evidence says they're all pretty much similar, right? They're short-acting insulin is a short-acting insulin. Well, coverage might be an issue, and in that big gold circle, you can see that anything in there is full Saskatchewan and NIHB formulary coverage. So that, if that's a concern, you know, those are covered. There's some that are just covered on NIHB in the blue circle, and some that are not covered at all. And then at the table below, there could be other things you need to worry about. I'm looking for once daily. How many of these basal insulins are actually going to last about 24 hours? I've got a patient who has bad hands for whatever reason. Which one of these are good for patients with really poor dexterity? Well, we highlight that. And which one of these carries a lower risk of hypoglycemia? Or, you know what? I've got a patient who's using a really big dose of insulin. I don't want them to have to do multiple pokes. If I can just get them to do one, my odds of ensuring optimal therapy are greater. So here are the options where we have high dose accommodated, as well as what are the max doses that you could use. And it's all put there so you can do a one-stop to compare all your options across the board. And speaking of insulin, here's a great patient tool. This is a visual infographic to discuss about optimal injecting and the use of insulin needles. At the top, we remind them if you're using those pens, keep it in the skin for about 10 seconds. Choose a shorter needle length that's more comfortable. As a community pharmacist, I'm probably going to give you the 4mm, whether you like it or not, unless you convince me otherwise. Reminder to rotate the injection site and to change your needles every time because it can cause a bit of discomfort or pain. So another tool, sometimes we just hang these up in some of our clinics and stuff just to stimulate conversation for patients to maybe ask us about if they're interested. So on our RxFiles resources page, you might have noticed that there is a type 2 diabetes and a chronic pain. We call them our mini books. We've actually compiled all our type 2 diabetes resources into a mini book and all of our chronic pain resources there. If you click on those, you will get all the tools at your fingertips. My apologies, got a little cough there. One thing you might be interested, especially if you've got an older adult population or maybe you're working in long-term care, is our Jerry RxFiles. And this book is much different than our charts. And often we got a lot of complaints. This font is too small. I can't read it. It's too much. This just doesn't work for me. So because of what our users told us, when we came up with a geriatric-based resource, I made an effort not to use font any smaller than 10. And it's a bit of a different beast, the Jerry RxFiles. Every therapeutic area essentially has 2 sections. And here I've got dementia, the behavioral and psychological symptoms that you may see. So this is more of a stepwise approach to assessing a disease or condition, looking at things that might be contributing to it, like other medications or other medical conditions. Of course, we talk about the non-drug options as well as the drug options in this older adult population. And this was designed more so for a long-term care environment, meant to be supportive to special care aides, LPNs, RNs, nurse practitioners, and physicians. And ideally, you could just go down the columns as you're assessing a patient for that particular condition to determine if there's a way you can optimize it with medications or with non-drug options. In the second section, with those various conditions, you will see tables of what we call potentially problematic medications that might be used for the treatment of the disease or condition. And this is where we pulled in the STOP and the Beers criteria. So the STOP and the Beers criteria, two tools that were existed to identify potentially, they say, inappropriate medications for individuals 65 and older based on either their health condition or just the fact that it's an older adult population. At one point, I know Beers criteria was used as a bit of a quality measure in long-term care, which is where this tool also came. So you can see that if you're looking at medication classes, maybe doing an assessment, looking for, maybe doing an intake, where can we optimize these medications? Here are the medications, here are the concerns in older adults, and maybe potentially what you can do about it or how to maybe navigate those concerns. So again, a great tool if you're dealing quite frequently with an older adult population. And in the GERI RxFiles and as well on our website, there are a few unique tools that you might be interested in. We do have a tapering recommendations for 15 different classes of medications. Not a lot of evidence out there for how to properly taper a medication. So this comes out of what evidence there is and product monographs and clinical experience from people who are well-versed in the area. So what you find here is antidepressants. Why do we need to taper them? What are common symptoms of withdrawal to let us know that maybe we are tapering too quickly? And how might we want to approach a tapering in our patients? Sometimes we break it down by individual medications. Sometimes it's more of a class effect. So here in this case, you happen to see individual medications essentially broken down into how you might want to approach a taper. Also in the GERI RxFiles, you'll find a list of medications with anticholinergic activity, something we want to avoid in any patient for whom cognitive impairment or dementia might be a concern. Red denotes medications with those moderate to high anticholinergic actions. Blue is low. It might not be a problem depending if we just have 1 or 2 blues on board or a lower dose, they might be okay. And then some other alternatives that you might want to consider if you're trying to avoid those anticholinergic actions. The crush list, this is also somewhat popular with my long-term care population. My patient can't swallow this pill. Can I alter it? Can I smush it up and put it in yogurt? Can I put it in water? What do I do? Is there an alternative? So this section, it's rather long in the GERI RxFiles, again, also on the website if you want to take a look. And on the left-hand column, you'll see the name of the medication by chemical and brand name. What dosage form are we talking about? Is it the tablet? Is it the capsule? Is it the immediate release, under the tongue dissolving one? And what can you do to alter it? Can I alter it? And some comments and considerations. So at the bottom of every page, you'll see that those symbols tell you what you can do. Check mark? Absolutely. Feel free to crush it, no problem. Water droplet, you know what? This will dissolve in as little as 10 to 20 mils of water. We've got an unhappy face to let you know that, yeah, you can crush it, but it's probably going to taste horrible. Some other symbols about cytotoxic, it's a skin irritant or teratogenic might be really important for those who may be administering medications and thus handling them. Got some tips on if you can open a capsule and disperse it into maybe applesauce or pudding. And we've got a whole section ahead of time on how to mask bad tasting medications in case you do need to crush them. So a great tool, again, to have on hand if you need to alter the route or the formulation when administering the medication. So we're coming up on our time. I'm going to leave you with 2 things. I see no one has thrown me some really hard questions, and I hope I've shown you some great tips about how the RxFiles can help you. But know that RxFiles isn't the only great resource available to you in this province. The Medication Assessment Center is a team of pharmacists, physio, and now social workers that you can refer your patients to, or they can refer themselves for an in-depth medication assessment. The MedSask Med Info service, you can call, your patients can call with any drug questions you might have. There's a team of pharmacists available to answer your questions. And maybe people have some nutrition questions. Well, Eat Well Saskatchewan does provide access to a registered dietitian for all those questions. And my very last slide before I open the floor is a shameless self-promotion slide, just to let you know that on June 23rd, if you weren't bored to death by me today, I will be speaking on buprenorphine naloxone, so you can see how we really dive into a therapeutic topic. But if you're interested and unable to attend that day, don't hesitate to send me an email. I'm happy to do a one-on-one presentation, whether it's 15 minutes, 20 minutes, 60 minutes if you've got lots of questions, or for a group. Just fire me an email, julia@rxfiles.ca. We're happy to help. And with that, I'll open it up if anyone wants to post some questions and throw it back to Carol.
All right, thanks, Julia. There was nothing boring about that presentation. It was fabulous. You make those tables with all those little boxes and stuff sound much easier to navigate than they are when you initially look at it. It's a little overwhelming, but some fantastic information and a great resource for RNs and NPs and RNAAPs in the province. So those of you that attended today, please get the word out to your colleagues. Julie has offered to take time to talk with anybody about anything medication related and help you, help you to navigate through this fantastic resource. So are there any questions for her? I see at this time so far there's not, but we'll give you a couple of minutes. So Julia, I just have the one question. I'm assuming you have resources like the one you showed today, a lot of resources for diabetes care. I'm assuming you have other resources like that, like several, or a number of resources for, say, one particular health condition, like say congestive heart failure or something like that. It's not just about the medication. It could be other factors in there too, like with the diabetes, your routine and your diet and all of those sorts of things. So is that accurate that you would have other resources like that for other health conditions?
Absolutely. And again, we always look to the evidence for first-line treatments. Turns out for many, it's a non-drug option. So we'll always highlight the benefit there. When you say heart failure, we actually have one of those, like the SADMEN medications to hold when you're dehydrated. We have one of those for heart failure as well. Right. How to adjust your Lasix or furosemide dose, information, booklets, again, on pain, addiction is another area we've focused on. We're not comprehensive. You won't find something on everything, right? But we also take requests for gaps where you think you might need a tool or a resource. We're happy to consider that and see if we can help out in that area as well.
Yeah, that's fantastic. It's really great. And your resources aren't just strictly geared to a healthcare professional. Lots of them are to the public so that people can self-manage and try and, help themselves, as opposed to just, perhaps relying on a physician or an NP or even an RN. There's things that they can do and strategies that they can incorporate into their life, change their lifestyle, and perhaps help their health too.
Yeah, that was the purpose of our patient booklets, which again are open source. No one needs to log in to access them, to help empower patients with the information they need to ask good questions, to help self-manage, because as healthcare providers, I suspect none of us are wondering what to do next. Right. So it really helps, again, us be efficient and support our patients in the best way we can.
Yeah, excellent. So I'm not seeing any questions from the floor. We still have all participants here. Is last call, any questions for Julia at all? If you are interested in the Suboxone presentation on the 23rd, I'm sure it will be as informative, and she'll inject her humor. Your shameless self-promotion. I had a giggle when I saw that. Okay.
Thank you.
All right, well, I've just got a few more slides here to share. The SRNA, as we are moving to a strictly regulatory body by this fall, we have started to take a look at our presentations, and we're trying to provide more of a regulatory perspective. So what we're doing with our presentations, whether it's us or someone else, is bringing to the forefront some of the standards and entry-level competencies that would apply to this particular practice. So having said that, I have outlined some of them here. Just be aware that these lists are not all inclusive. There's certainly other standards and ELCs that apply, but these are the ones that we feel are most important. Okay, so standard 1, professional accountability, or sorry, responsibility and accountability. And I'm sorry, I have another one there. I'm not sure why. Anyways, being accountable and accepting responsibility for your own actions and decisions. So again, if you're not clear about something medication-wise or in anything in patient care, please get some clarification. Standard 2 is knowledge-based practice, applied knowledge from nursing and other disciplines concerning current and emerging healthcare issues. Oh, I didn't proof this really well, obviously. Anyways, so the discipline of pharmacy, applying those principles that you've learned in that, gaining more information about medications that you're delivering and seeing how that is affecting your clients. And proactively seeking new information and knowledge, employing a critical inquiry process and utilizing best practice in the provision of registered nursing care. And then the entry-level competencies, and I should be clear, these are the registered nurse entry-level competencies and practice standards I have here. So the first one is clinician, provides a safe, ethical, competent, compassionate, and client-centered and evidence-informed nursing care across the lifespan in response to client needs, applies knowledge of pharmacology and principles of safe medication practice, incorporates knowledge from nursing science, social science, humanities, and health-related research into plans of care. And I would say RxFiles has a wealth of health-related research in their information. Uses knowledge of the impact of evidence-informed registered nursing practice on client health outcomes. Communicator, uses evidence-informed communication skills to build trusting, compassionate, and therapeutic relationships with clients. Collaborator, demonstrates collaborative professional relationships. So it's not just about the care that registered nurses provide, it is a team environment, and certainly pharmacy is part of that team. Coordinator, consults with clients and healthcare team members to make ongoing adjustments required by changes in the availability of services or client's health status. We are advocates, resolves questions on unclear orders, decisions, actions, or treatment. An educator selects, develops, and uses relevant teaching and learning theories and strategies to address diverse clients and contexts, including lifespan, family, and cultural considerations. And again, I think RxFiles has, as they showed us with the diabetes, there's a lot of patient teaching materials that I think would be very helpful for a lot of people. So that's the end of our webinar today. These are just questions, takeaways. I see I do have one question in the Q&A. I'll just check that first. It says, not a question, but thank you for an excellent presentation. So somebody's very happy with it, as am I. Okay, so the questions and takeaways, just things to think about when you leave. You don't have to send anything in, but just things to consider. So what's the biggest takeaway, your biggest takeaway from the webinar today? What connections do you see between the standards, entry-level competencies, and the code of ethics in the information presented? And are you able to apply the information presented to your current practice? And we certainly hope that is the case, as this was a fantastic presentation. So the last thing I have a poll question. All right, so just a poll question. Did the webinar provide information or resources to support your practice of safe, competent, ethical, and culturally appropriate care? So if you just click on yes or no, attending as well. There we go, 100%. There you go, Julia. You obviously didn't bore anybody. They're quite happy with the presentation today. So, all right, well, thank you so much for joining us, and we'll see you again in a couple of weeks for Suboxone. We do have a webinar next week on ageism, which is going to be presented by the Saskatchewan Seniors Mechanism. So please tune in for that one. As we all know, especially COVID has brought a lot of it to the forefront. There's lots of issues with seniors and one of our vulnerable populations. So I think this ageism will give us some good insight into perhaps how we think about seniors and how we should maybe better think about seniors. If you've missed the webinar, any webinars, you can view them on our YouTube channel. And again, Julia, thank you so much for joining us.
Thanks so much for tuning in, everyone, and for giving me the opportunity. Have a great rest of the day.
All right. Bye-bye.
Bye, everyone.